lecture is basically about serum levels of testing. And for those of you that have been studying, you know you have several choices. And I'm going to tell you the bottom line from the first. So you can listen to this and then you can leave if you want right after this. It makes sense in my practice, and he said at 40 years he was being kind. I've been doing this 42 years, and yes, I've written 4 textbooks, and the truth is, every compounding textbook in the world except for Lloyd Allen's is mine, and I wrote the only textbook on intravenous nutritional medicine. The truth is, serum has a lot of advantages. Is it perfect? No, none of them. None of the methods are perfect, but it's a matter of several things which I will show you. That is efficacy, how fast you can get it back. Is this particular way of doing it going to give you time? And also at the end of the day, this is non-CME'd, so I have no problem saying it's okay for you to make money. And how do you do that? If things are delayed, it will become difficult. It'll become much clearer as I go on through this particular lecture and explain to you all of them. How many in the room already do serum laboratory testing? It's about half. And the rest of you, do you do any hormone testing? Raise your hand if you do saliva, urine, anything. Okay, so this is not a convince job because that's not what I'm here to do. This is just for me to introduce myself and you to serum testing. For those who do it already, maybe take you to another level. And specifically to also tell you, because like I said, this doesn't need this slide because it's not done by any certifying agency, so you can easily, I could say what I want in my opinion. I can tell you from being with Access, he was kind saying 10 years because he's trying to show my age, but I've been with Access for much longer than 10 years as their chief medical consultant clinically, so I talked to probably several in the room, if not many of you will if you choose to go with Access Laboratories if you haven't. The one thing about Access I tell you up front, as I told you, I tell you the bottom line. Number one, they basically turn things back as fast as any company I've ever seen with amazing, amazing accuracy. I've had, if I told you, no less than 25 companies in my career, the only one that ever got my blood work back the next day happens to be Access with amazing accuracy. And the price, of course, well, with me, no, with everyone, I pay the same as everybody. With the price-wise, it is better than every single other company out there. So that's my advertisement only, but I'll take you through this. And let's go through this because what my job will be is show you most of the hormones that are by serum identified, why they are, what's important about them, and then we'll continue to any questions you may have, and I'll try to get done about 10 minutes before. Unfortunately, at 10 o'clock, I've got to go because I have a flight. So I'm going to do my very best to leave a little bit of time if possible. There are 3 hormone testing methods that are pretty well known. There's serum, there's urine, and of course, saliva. So let us take for 1 minute the overview. If you learn nothing else, this one slide will do it for you. Serum testing as well as saliva testing are both a point in time. We take your blood now, it's now. We take your saliva, it's now. Now, you can do sequential testing. That is possible. You can do blood work today, blood work next week, etc., and you will get sequential tests. You could do that with saliva as well, but for just the basis of the test alone, it's that point in time. So if you do a testosterone or a blood test, they're a point in time. The difference between that and urine testing is that urine testing is not only particularly 24-hour excretion, it is more dynamic, it is an entire day. It also looks at the downstream metabolites. So the most accurate is urine. So you should say, why am I standing up here talking about this? Well, urine's extremely expensive testing. Most of the time you won't have a clue what to do with the metabolites you see in the urine that comes 6 pages thick. And also, it is very difficult because there's patient compliant issues. Go home, it costs a lot more, you're going to wait 2-3 weeks, it will hold up your treatment and your protocol. So it is the last thing I do. If I do it twice a year, it's a lot. The first 1 and 2 I do often. As a matter of fact, I do serum every single day in my office. Pretty much that is my go-to. The other thing on the bottom of the slide is basically saying that when you get saliva, you are getting the free component of a hormone. So when you ask, for example, testosterone, you have to ask for a free and total testosterone so that you get the free component too, and you'll see why in a moment. But I think you should know straight up front, if the saliva is not collected properly, you will get nothing more than a test that is bound, and it is just like getting for example, testosterone will be the same thing as if you get a total testosterone. And you could say, wait, what do you mean? So in the saliva is typically the free component only. But how many know how that could be skewed? Does anyone know how you could skew that, Doc? You could floss. What happens if you floss? You're right. And I'll tell you one just in between that's perfect, which happens to every time I go to talk to someone who has saliva hormones that are elevated more than they should be. And not even flossing. 50% of the population has at any given time gum disease. And even a microscopic drop of blood, a microliter, will raise that finding to something that looks either normal or high. Why? Because we're measuring in such small parts. So if you do saliva, you choose that as your go-to, just make sure that you tell someone, rinse their mouth out 15 minutes before with cool water, wait 15 minutes, at the end of 15 minutes, then they collect. But that collection tube, which is very small, should take at least 30 to 40 minutes. If it took 5 minutes, I assure you it's not accurate. And that's what happens, and I tell people all the time. If you're not taking, by welling up the saliva and drooling it, if you spit one time, you bring saliva through those teeth, and you're one of the 50% that has gum disease, yep, you end up with a result that's worthless for you as a clinician. So just keep that in mind. Serum, no problem. I take serum, I draw it, I get an answer. I don't have to wait a day, 2 days, literally overnight I'm gonna get my answer because they do it in-house. So first of all, choosing a method, you should be aware that hormones are pulsatile. They pulse, and if you miss the pulse, you won't get the peak, you could get the trough. So the pretty much clinical takeaway is that whatever you do, you should keep it within time zones that are keeping with what you're doing. For example, testosterone elevation is typically 6 to 7 in the morning. Women vary a little bit more than men. You're not going to beat your office 6 to 7, but in the morning hours would be more appropriate than having someone come one day in the afternoon, one day in the morning, and you're saying, look, it's not working what I'm doing. That's not necessarily true. The other one that's the most important, which we'll see a little later, and I'll glance over because I'll tell you now, is growth hormone. Growth hormone's pretty much a wasted test when it comes to any type of testing because growth hormone is always reported out as less than 10. And unless you catch the pulse, you will never know. And the only way to be able to really determine it is by taking someone to the emergency room and doing an L-arginine test, which of course could drop their pressure and cause a whole bunch of other problems, so you're not going to do that. So the one way you'd be aware is that these things are pulsing, try to get within the times and the days of the month. For example, when you're treating and looking for estrogen or estradiol in a menopausal female, it's best to check her somewhere between the 3rd and the 5th day in the follicular phase. That's all. So that's another thing you should just think about as you do it. So important things you need to remember as you see in this slide, when you put topical applications, it's going to have a marked increase saliva hormones, but it's not going to change the serum. So the serum is going to be more of a steady state that you can see. So if you're putting something or you're telling patients to do this, then it's going to be different than someone who you're putting pellets in or someone who's taking it by shot, for example. You want to be able to check what you're doing because these fractions will come through the skin into the saliva. Again, it's advantage of the other as well. There are several testing methods that I will not spend a lot of time on, but to tell you they look like this. They are bioassays. They were the original ones. There's radioimmune assay, RIA, which was fairly accurate and good. And then came along the most accurate way of testing serum that we have. I'm sorry if I'm in your way. The most accurate is the combination of liquid chromatography and mass spectroscopy in tandem. Now that's what Access uses. So when you are testing with the bioassay, this is a long determination. We did this years and years ago before our new equipment came in. I don't remember if we ever did RIA, but it too is accurate, but nothing is more accurate than the liquid chromatography mixed with mass spectroscopy, LC-MS-MS. It's in tandem. Now, why is that so good? Because of all the things you would like, you would want not only, you want specificity, you want it to be very accurate, and this measures for the most part as low as parts per billions. Now think about when you're looking at hormones, parts per billion, and you suck something through your teeth, blood that is, even a little amount, it's going to shoot it through the roof. And you can say, now you know why. Excuse me. So when you talk to a patient and they told you they collected it wrong, you'll be able to clearly tell them this is why that happened. In a serum specimen, it's 1, 2, 3. It's easy, and we're measuring in such a fine particle with a machine that is considered the industry standard now. Everything else is not as accurate as LC-MS-MS, nothing. And this is what it looks like if you like to have something to look at, but the key to the slide is the specificity and the sensitivity is of the best of all other methods of determining the hormones in someone, and that's what makes it important. Hormones fall into two categories. There are hydrophobic and there are hydrophilic. Do you need to know this? Not really, but you should be at least know that the hydrophobic ones are the steroids. They're your testosterone, estrogen, progesterone, cortisol levels. They're the ones for the most part that you're looking at. The other ones like catecholamines, etc., they are more hydrophilic. The difference is, and so you have a basis to know, is to look clearly. The hydrophobic ones do go completely as the free fraction, they go through into the cell. They enter the cell. The others are basically held back by the cell membrane. But let's stop and pause for a second and ask the most important question. Why are you testing hormones anyway? Anybody give me an idea? Why are we testing hormones? What's so important about a hormone? I dove into this, but I never took the time to ask why is a hormone so important? Why? There are hundreds of them, but why are they important? The reason is that they allow for intercellular communication. They're pretty much controlling intercellular communication. God, or whatever you believe in, from your head to your toe, has put a receptor for testosterone, estrogen, progesterone. They're not just sex hormones, because that's how they were originally classified almost 100 years ago. It's basically, these are things that allow for cells to talk to each other. So for example, if you study and learn completely nutrition, if there is no good hormone connection, you're not going to get the results in that patient that you're expecting. Same thing if you do mind-body or anything else. All of it needs to work together. So to make sure that you have good intracellular communication, by the way, what I just told you physiologically is the reason you'll tell your patients when they say, well, I'm older, it doesn't matter, my husband, we're not into sex anymore. That's when you go, no, Mrs. Jones. That's not what this is about. This is about other things that keep you healthy long term. These hormones allow for communication of your 100 to 200 trillion cells. This is what gives you your strength, your cognition, et cetera, which you already know. Those are the things that you want to present to the patient. That's the reason you want to do hormones. And of course, the other is for other people that have interest in libido, but it's not just about libido by any sort. We also classify hormones here into several categories, as you see here. There's amines, which of course make the melatonin, thyroid, catecholamines, and steroids, and it goes down the line up to eicosanoids, which makes the prostaglandins. You don't need to memorize it, but certainly you should just be aware that hormones categorize themselves as best as we have been able to do as researchers and physicians to put them in categories, just so you have an idea where they come from. But pretty much all the steroid hormones come from cholesterol, And that's the most important thing you need to know if you don't already, because if you drop cholesterol by using cholesterol interrupters, or you think that someone's cholesterol should be 150, 140, or whatever, you're going to harm their hormones. Cholesterol is an antioxidant. As we get older, cholesterol goes up for a reason, and we need to be able to convert these into steroids for a reason. So for sure, don't look at cholesterol as a bad guy. It's not, and that's a discussion for another time. And this bidirectional effects, which is really important, I think pretty much everyone in the room should be aware that our emotions are very much in sync with our hormones. I think anyone that's ever experienced a premenstrual tension, men as they get older, the difference, they're angrier. Men and women, we don't think as clearly when our hormones are up. We're not as settled. We're anxious. And all these things that are emotional that end up in a psychiatrist's office often, and then they put them on Wellbutrin or something of that nature, may have been taken care of just by realizing that this slide is basically saying you should look at hormones. Now, I get probably, I would say, 10 or 12 referrals from psychiatrists a year who basically, when they have an enigma on their hand, they'll send me the case. And pretty much, I can always find something not right in the hormones. And that's where you start to go, and that's where you begin. And here you could see the endocrine communication and what happens. The biggest thing that you should be aware of, it's hypothalamic to pituitary. There are hormones in the anterior pituitary, most of the ones that we're talking about today, and a couple in the posterior pituitary as well. And of course, there's a feedback loop that you'll be able to see and encounter shortly as well. Okay, so this slide basically is showing the hypothalamic pituitary adrenal axis and how the circadian rhythm occurs. You probably should have a very good handle on how this works, because you have people in your practice that come to you that talk about fatigue, and it may be nothing more than the sleep-wake cycle is not set properly. They're night workers, they're stressed out, and in this day and age, people are very stressed out, as you know. So this axis and the adrenal glands, which we whip so hard by stress and coffee and everything else, and cigarettes and everything else, and go, 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 and not getting enough sleep, tends to tear apart this axis, and then eventually leads to, of course, the dysregulation or the downregulation of certain things. And you can see how this works. There is a light cycle. There's light and dark. We need to be up before 9 a.m. We need to get sunlight in our eyes because it resets that cycle. In the morning, what hormone is the highest, by the way? This is a good question for you. Cortisol is up in the morning. That was good. One other with the sleep-wake cycle. Give me one more. And I will we'll give you like a free blood test or something today. No, just kidding. What sets the sleep-wake cycle? I'll give you a hint. Melatonin, but melatonin is highest at midnight, 1 o'clock. So what is in its opposition that does this? So in the morning, it's elevated. It will help you because it's a clinical way of helping your patients. Cortisol, no. Good, you're cheating. Okay, I just want to say that. No, good choice. They are also elevated in the morning. The answer happens to be, nobody? S-adenosine methionine. SAMe is elevated in the morning. So if you want to reset someone's sleep-wake cycle, between 7 and 9 in the morning, you can give them anywhere from 800 to 1,600 milligrams of S-adenosine methionine, and give them their melatonin at night, because that will reset the cycle. But that was good. Yes, cortisol's up in the morning, DHA's up. You're all right, but what's that? I was very tricky. I like to be tricky. All right. So hormones are based upon either a feedback loop, which is either negative or positive, and there's examples of that. You know, when your thyroid's elevated, your T3's up, it will go back through the brain and turn off the anterior pituitary producing thyroid stimulating hormone TSH. We have also a positive feedback. So when there's an LH surge, luteinizing hormone surge, it tells the estrogen to turn on at that point too. And of course, it starts to lend itself to getting ready for having a period. And in men, by the way, it also has to do with whether you have testicular arrest. So when your LH is different, it will cause that as well. Here is a comprehensive list. I'm going to take it off the board. I want you to memorize it right now. Just kidding. But what I put that there, these symptoms are so common in every single patient that walks through to your office or comes to see you online, however you're seeing that person. And this list is not even exhaustive of the things that that can go on. And I think you should take this slide, you have it, look at it, and just prepare yourself for the next person that walks in, that these things that are on the board right now are definitely going to affect that patient if you don't look at the hormone balance, regardless how good your nutrition is, regardless how good your acupuncture is, if you use that for energy balance, chiropractic manipulation, whatever, none of it will work unless you have hormone balance occurring at the same time. So that's important. So why is it important? We put 42 billion pounds of chemicals in the air pretty much per day. That's per day. They're in our food. You have phthalates. Pretty much when the Environmental Protection Agency looked at children, all of them had mercury. Of 100 cord blood samples they looked at, all of them had levels of phthalates. That's plastics. When you take receipts, money, everything has a phthalate in it, a plastic in it. They specifically will interfere with hormones. So that's why it's so pervasive, why you should be doing testing, hopefully serum on everything. So you have really two states, and I'll explain the two states exactly the way I tell a patient, because often you're telling a patient something in your language, they don't get it. So I'll tell you what's been very successful. You could paraphrase it, change it, whatever you like, it's yours. I tell a patient there's two components of being. You can either be in what we call a youthful state. Now, a youthful state is an anabolic state. An anabolic state is described in a subscript as wear and tear is much less than repair and restoration. That simple. If you have more repair and restoration than you do have waste and problems on this side, that person's in an anabolic state. Pretty much, unless you are super vigilant about your own hormones, you will not be in an anabolic state once you pass like 40 years old. How many in this room know for a fact they're in an anabolic state? How many in this room have checked their hormones one way or another in the past 6 months? Nobody. So that's something you theoretically should be checking at least every 6 months, because you want yourself in an anabolic state. Youth, remember, is described wear and tear much less than the repair and restoration. That's being youthful. Otherwise, you move into this other state where you're catabolic, and of course, that's heading towards the light. We don't want to do that for ourselves and our patient. This slide basically shows how these hormones are metabolized. You should be very aware in your studies where hormones metabolize, because your intervention is going to be dependent on knowing that. Without knowing whether or not your hormones are being metabolized, you will get buildup in your patients of other things. That's why the weightlifter that's taking a lot of anabolic steroids loses their hair. The woman that comes in with acne or loses their hair, it's because there was no thought of the metabolites that could occur. And that's something that you should be looking at, and of course, moving accordingly and using your thing. Now let's talk about serum. Pros and cons. When I was in 1974, a long time ago, I was the Pennsylvania karate champion. I learned one thing that was, I thought, very well to pass on to others. And that is, there are advantages and disadvantages to everything. Every weapon I used, every way I fought. So my disadvantage was I was short. I made it up in speed. So if you know what your disadvantages are, and you know your advantages and disadvantages of your opponent, then you're going to be the best at what you can do. The same is here. So let's go through these for a second. First, let me tell you, I have a patient that comes to my office, and I'll see them as a new patient. I'm going to go ahead and get my blood work done. I get a few tests. Blood work's imperative. I never, ever, ever treat on my first visit. Never. Because I don't know enough about that patient, even if they bring me a stack of records. I want to know exactly that person's biochemistry. So I'll draw serum levels. Why serum? Because I'll get my answer tomorrow morning. I know if I send it to Access today, and today's Friday, Monday morning when I come in, I already have some answers for that patient, and I can go ahead when I have a reliable lab to be able to schedule that patient as they walk out. I don't have to wait whether, did you do your serum, did you do the urine, did you do this? I have my answers immediately. That's the first thing. Number two, it's extremely convenient for the patient. It's so easy. They take their blood, they get their answer. They'll foul up stool samples, they'll foul up urine samples, they'll foul up everything else, but serum, that's up to your nurse. You should be able to do that in 2 seconds. The reference ranges are very well determined in serum. They've been around for a long time. And again, using LCMS, the accuracy is amazing. And this is the other thing. It's covered by health insurance. Now, I know some of you will do saliva, some of your cash practitioners. I'm a cash practitioner totally, have been since 18 and a half years ago. But I'll still do my patients a favor, and I'll send them out for, or I'll do their lab tests. So, and even if they're not, the most inexpensive way is no question to do serum, and again, get my answers quickly. So what are some of the disadvantages? Well, it may not represent the pulsatile manner of the hormones we talked about orally. Well, guess what? Neither does saliva, but we already discussed that. Only urine, if it's a normal day, you'll get a 24-hour result. So other than urine 24 hours, very expensive, time-consuming, long, I'm not going to get that answer either. But if I'm very cognizant of the time I'm drawing it, and cognizant of the part on time of when they are in their cycle, it will make a difference for me very easily. When they say there's no distinction between free and bound for the sex hormones except testosterone, that's not necessarily true. Yes, testosterone, you have to ask for free and total. I'll show you in a minute how we do that. You can get, when you get DHEA, most people get dehydroepiandrosterone, DHEA-S, which is sulfate. It is a bound, but you can ask for the free DHEA as well. We do that. You can get plain DHEA if you choose. So that is also a possibility as well. And of course, you're not going to get the metabolites because only urine's going to give them to you. Saliva doesn't give them to you either. These are the commonly tested things that you can get in serum, except maybe for oxytocin we don't do. Pretty much 99% of what's up on that board are the kind of things that you can get. Now, a good panel of hormones should include the 8 sex hormones, a full panel of thyroid, TSH, T3 free, T4 free, TPO, antithyroid globulin, I'll show you in a minute. They're the ones that you should be getting pretty much on every single patient that you see when you start seeing them. If you do not have a comprehensive lab panel when you start, how in the world do you know the biochemistry of that individual? How do you know what to do for them? Well, you don't. You're going to take a guess, and the guess is going to lead you probably in the wrong place. This is the broken up, as I told you earlier, the anterior pituitary, pretty much secreting the hormones that tell the end organs what to do, and just antidiuretic hormone and oxytocin from the posterior pituitary also that will be produced. So normally we're looking at the anterior pituitary. Let's talk about thyroid hormones for 1 minute and give you some clinical things about doing serum. Serum is extremely accurate with thyroid. That's because you don't have a urinary one anyway, and you don't have a saliva one anyway. So this is the most accurate way of knowing. The only thing you need to know is this test is not accurate enough by itself. TSH is not accurate enough to tell you whether that person is hyper or hypothyroid. There is a test that you should be doing on every single person when it comes to serum thyroid testing, not only the first time, but serially, as I'll tell you in a minute because I'm building the question up. And it will tell you because 95% of the population in the United States has this that causes hypothyroidism. I'm giving you the hints. As a matter of fact, if one of these tests are elevated, then you can rest assure your patient, not really, within somewhere between 2 and 7 years, they will be hypothyroid. What test am I talking about? Which one? Antibody testing. Yes, smart doctor. What'd you say? You're saying cortisol again? I'm just kidding. I'm just teasing you. Yeah, reverse T3 is part of it too. But yes, it is the thyroid antiglobulins. How many in the room, when they see a patient, are getting full thyroid profiles with thyroid antithyroid, then you're doing a good job. And don't be afraid to repeat it because it will go up. Just a TPO, which I'll show you in a minute, if it's greater than 120, which is not very high, because I know you've seen much higher, TPO greater than 120 is associated with horrible symptoms. The higher the TPO, the worse the symptoms are. So be aware of that. And yes, you should do all these that are on there. It was on the screen already, so, but I know you knew it anyway. It will tell you everything. So you live with TSH. The truth is TSH is not overly accurate. They say up to 4+ in most labs. The truth is if I see a TSH and it's more than 2.2, I know something's going awry. I look carefully at the other ones very quickly because the TSH is not that clear. All thyroid testing is not great, and you should couple it with morning oral levels. Before someone steps out of bed and puts their foot on the floor, you should look at their temperature. If their temperature every morning is consistently less than 97, they probably have subclinical thyroid disease, and I would watch their thyroid function pretty much every 3 to 6 months. So, boy, that went, I don't know what that's doing, but okay. So anyway, T4, you want to get the free form of T4. You want to get the free form of T3. They are available. Can we see why that's flashing? Because I'll be hypnotized and I won't know what I'm saying in a minute. The free form of T3, the free form are free T3, T4. They are the unbound forms. They are the ones that are going to be the active forms, T3 being the most. Let me see if I change the slide. Yeah, it did it. Okay. T3, of course, T4 has to be converted at the tissue site to T3. That is the active form. That is the form that will go back in the negative feedback loop to the anterior pituitary and will tell the anterior pituitary, look, we got plenty of thyroid, we're good. So try to explain that to patients because patients sometimes say, look how low my TSH is. My thyroid's not working. No, that's not how it works. And you have to make them a little picture and explain to them, but you want to know the free T3. You also want to know that T3 is the only thyroid that is cardioprotective. They found in congestive heart failure patients, cardiomyopathy patients, every one of those patients you should probably put on a low dose. You can have it compounded, maybe 5 or 10 micrograms a couple of times a day, time release of T3. It actually is cardioprotective to a large degree. They should be taking it. One of the components that we have to also measure, which we measure also at Access all the time, especially for me, I wouldn't work without it, is the reverse T3. Typically, the endocrinologists are not measuring this. They're not measuring even free T3. They're measuring TSH, T4, and they're making their clinical decisions based on it. It's far from being accurate, unfortunately. But if you look at the T3, and this is how I explain it to a patient too, the T3 is the free component. For example, he's free in the room. If I told him, do me a favor, would you just fix my papers, grab my coffee? But he's in the room, he's free to do it, but he goes like this, what are you kidding? I'm not doing that. That's reverse T3. That's how you can think of it. That's my example of it. You can think of it any way you want, but reverse T3 basically is non-active, non-usable. So you should be able to do a ratio. I don't know if I think I put it in a slide. Let me go back. I did do it. I did it in a slide. If you take the T3 free and divide it by the reverse T3, that ratio, yikes, that ratio should be 0.20 or greater. If you want to multiply it times 10, you could do that. But I just look at 0.20 or greater. If it's down at 0.12, 0.14, there is way too much reverse T3 in comparison to having free T3. That person you need to treat clinically. They're not getting the amount of free thyroid that they need. Is that, as everyone understands, a very important point, and you should be doing this test regularly. Yeah? You need a little, yes, some compounded T3. I mean, if there's an asymptomatic and everything else looks good and it's only 0.18 or something, you'll watch it. But let's say it's 0.12, 0.14, 0.15, that's low. It means you don't have a lot of the active free form ready to work T3, which you need for these patients. Leave them. You can leave them. You can add just a little bit of 5 micrograms of T3, time release up to 10, watch their temperature. Once their temperature normalized, you could stop. You could put people, I have some people on 40 micrograms twice a day. I wouldn't start there. I mean, you start real low. And I think you'll find it's important to take. Does everyone understand this concept before we go to the next slide? It's important. Okay. Next is the antibodies, which we talked about, how important they are. Serially test them. These antibodies, you know, when someone has Hashimoto's thyroiditis, as I told you, if you have a positive antibodies today and all your rest, TSH, T3, everything's fine, that doesn't mean things are fine. It's not fine. It means in the next 2 to 5 years, 7 years, that person's getting hypothyroidism, that person's getting Hashimoto's thyroiditis. And these thyroid disease, when you have these antibodies, it also lends itself to other autoimmune diseases. How many in the room on a typical comprehensive initial eval do an ANA? You don't look for antibodies. Well, you should, because 8 out of 10 in this country now have them every single time. They may be low titers, 1 to 40, 1 to 80, 1 to 160, but something's not right. They don't have a specific one of the 84 autoimmune disease complex, but they do have something coming. You should add that to your tip. It's a serum test. It's easy. It's inexpensive. And normally when I order it as an ANA with reflex and titer if it's abnormal. If it's not abnormal, they just report it out 1 to 40 or less. It's easy. All right, here's the overall slide that you should pretty much have in your head as best as possible. Everything begins at cholesterol. There is a couple things that are missing from the slide, just to give you a little bit clinical idea, things that I think about in here. For example, progesterone is also degraded by the 5-alpha reductase pathway and a desaturase enzyme in females, men in the 5-alpha reductase. And it makes another steroid called allopregnenolone. Allopregnenolone is what women in postpartum depression pregnancy have a lack of. It also has to do with being depressed and not feeling good. And so if you block, just a thought for a minute, just think about it, there's good and bad. You don't want the testosterone to always convert to DHT because of hair loss, pimples, things of that nature. So you'll use something, maybe you use saw palmetto as your 5-alpha reductase inhibitor, maybe some of you use finasteride, whatever. But if you're too harsh on blocking that pathway, you'll block the production of allopregnenolone, and people will get depressed. So if you have someone that you're giving these things to, I'm doing a great job, all the numbers are good, but they don't feel good, start thinking, did you press the metabolites too hard? It's a component of possibility as well. The other thing that you don't see in this as well is that the adrenal steroids that you see here, cortisol, estradiol, cortisone, you're familiar with DHEA, you're familiar with pregnenolone, I would assume. We'll show it to you in a minute. You're familiar with cortisol. They all come, aldosterone from the cortex. There's one other that come from the cortex. Has anyone heard of strophanthin, G-strophanthin? Oh, I've got a great assignment for you. When you leave here, check out G-strophanthin. Do some research. It's actually a cardiac tonic. People that have high levels of G-strophanthin, digital is actually very closely related to it. Wabane, we used to have a drug in this country. It's still in Germany called Wabane. It actually helps the microcirculation and reduce lactic acid. As a matter of fact, there's 10 times less heart attack if you have G-strophanthin and you're coming out of your adrenal gland or you're taking a substitution for it. And you could see that young people don't have it, so there's no problem. More stressed you are, which is pretty much everybody nowadays, that isn't produced. And if you ever do a digitalis level on someone and find there's a slight elevation, and wait, I forgot, that person's not on dig, it's this Wabane that's being produced, or strophanthin. It's worth the time to go read about it and learn about it. If I put you in that direction, it's a good direction to learn on your patient. Pregnenolone, of course, is one of the 2 youth hormones. There are 2 of them. I will tell you easily. Pregnenolone, DHEA, anabolic state, wear and tear, much less than repair and restoration. Pregnenolone in the 25-year-old, maybe up to 32 women keep their precursor hormones longer than men do. They don't break off as quickly. Pregnenolone's 220, 230 when you're 18 to 20 some years old. Take a look at what most of your patients are now. If you're not assaying for it, I assay for it every day. DHEA 450 to 550 in young people, and watch what it's assaying for when people get older. And you'll find that theoretically it's supposed to break off about 10% these per decade, meaning if it's let's call it 400, by the time they're 40, it should be maybe 340. You'll see a huge difference. They're not there. That's, again, the adrenal glands being whipped so hard from stress, coffee, pesticides, everything under the sun. So you should replete them and keep them in the right category if you're monitoring them correctly all the time. And you could see them here, how it's made. DHEA, we just talked about again, and the goal, they say here, is 250, 350, 450. The truth is, goal is 450, 550 to keep it elevated. If you want the free form, ask for DHEA unconjugated. That's the free form. But if you're comfortable with the S, that's the bound. You can use that. So let's talk about testosterone for a minute. It is an anabolic steroid. You know that. But the biggest point on this slide that I want to introduce you to is how it's reproduced in a serum. You could get one of three answers in your serum. You can get a total testosterone, which is everything. Everything that's bound to albumin, everything that's bound to sex hormone binding globulin. That's the total. Always ask for the free. The free is only 1.5 to 2%. The free is totally free. It's able to do like him, to get the coffee, walk around the room, do whatever it wants. When it's free, it's working. So even if you have a very high total testosterone, very low free, that person probably should be repleted and treated. There's one other category that is also reported, which is the bioavailable. The bioavailable is the free component, and that component that was bound to albumin. I told you testosterone and estrogen are either bound to sex hormone binding globulin or they're bound to albumin. Albumin's a weak bond. So they feel maybe the most accurate's the biologic, but I typically will go just with the free component to give me the answer. The biologic will give you pretty much supposedly the most accurate because some of the bound albumin will disassociate and it will do that. And so it's probably the most useful measurement. Now, we don't need to talk about all the things testosterone does. And I know you hear it in your practice. I bring you this slide that you can review for later. But if you want good bone health and for patients, if you want them to be mentally and cognitively pretty much in great shape, if you want them to be able to have a good libido, which should be the last thing you say to someone because that's one, they may say, well, that's not my issue. If you want them to keep their muscle strength, and we know that sarcopenia, loss of muscle, is probably the #1 anti-aging physical sign that you can see, then you need to have this in your bag of tricks. Your armamentarium should definitely work on testosterone, not just testosterone, but all the others as well, including sleep. And you can see how the levels go and how they differ, and typically they're elevated in the morning. As I told you, men, as we get older, we tend to get blunted receptors. So in a man, taking it, you don't have to take it first thing in the morning. That man often doesn't have the same erectile potential in the morning that they did when they were younger. As they get older, their levels fluctuate a little bit more. But still, why don't you be consistent with your blood work? Just take it at the same time every day for whatever you start. That's what you should stay with, for sure. And again, we talked about the bioavailable and where it's at. Now, this is basically overall to tell you that testosterone is more useful than not. Everybody always does this. Is it positive or negative? Is testosterone causing cancer of the prostate? You'll hear patients say that. And of course, a lot of that was based on studies that were done on 2 or 3 people, not very accurate. But for the most part, who feels the best? An 18-year-old or an 80-year-old? For the most part, who has the most prostate cancer? The 18-year-old with the most testosterone or the 80-year-old, which has much less unless it's been repleted? And the answer is obvious. So prostate cancer is not because of testosterone. It's because of the metabolites and changes in the receptors that allow it to grow, and those things you should be taking care of and handling. Again, here is Dihydrotestosterone, another thing that you can easily measure by serum. I don't measure it every time, but I'll measure it in someone that's been repleted and they're having any oily skin or they're having pimples, they have some hair loss. You want to make sure that the DHT levels have not been accentuated. Remember, testosterone that's here either stays as testosterone or it will reduce to estrogen. That's how most estrogen is made, or it will go to DHT. And you should be aware of which pathways are being accentuated. Such an example in a man, the aromatase pathway, of course, is accentuated. The older we get, the higher our estrogen. And sometimes even after the age of 50, the average man has more estrogen than a menstruating female. So you need to cut that pathway with an aromatase inhibitor sometimes. And then you have the woman who also has aromatase activity to make her testosterone. And not just for cancer do you want to cut it, but you want to make sure it's not too aggressive either. So you have just the perfect balance of what you're looking for. Sex hormone binding globulin is an interesting thing. We talked about it before. It binds both estrogen. It will bind testosterone. It goes up as we age. It is a liver created type of substance. It goes up as you age. Vitamin D, magnesium, chasteberry to some degree, increasing testosterone, stopping coffee, they all will help to reduce the sex hormone binding globulin when it's elevated. And you're going to see it elevated. You want to know some things to do? I just told you. Estrogen, of course, goes through either the theca or granulosa area, and it goes either from cholesterol through testosterone and or androstenedione. In the theca area, it's converted to estrogen. It's also in the granulosa converted to estrone as well, and it's done through the aromatase pathway. Just aside. How are we doing with time? How much? Oh, I can do this. All right. So one of the things that I often ask for is total estrogens. It is also a blood test. It's easy to get. Total estrogens will give you E1, E2, E3. You want to know that, especially if you want to know whether that woman is more likely to get a cancer or not likely. And the ratio I gave you is on the board. If you don't know it, make note of it and keep it. If you take the E3, the estriol, and the ratio to E1 estrone, and actually plus E2, it should also say plus E2, the ratio should be greater than 1.5. It's a simple thing to do, and if you actually do this pretty regularly, you'll have a good idea whether your treatment's working well, and especially if some woman already has had a breast cancer or something in her family, you would like to know this for sure. And of course, the estrogen metabolites, we're not going to take much time on, but to tell you, most of them are in three categories. 2-hydroxyestrogen, non-proliferative. You want to improve that pathway. How do you improve the 2-hydroxyestrogen metabolite? How do you encourage that pathway? Someone name me a substance. Yeah, diindolylmethane, and lots of it. Even 300, 400, 500 milligrams will encourage it. And don't say indole-3-carbamol, because indole-3-carbamol has to be converted, and if you have the wrong acid in your stomach, you'll create increase in stomach carcinoma. So stay with the DIM. I like that.
What do you think about the combination of the two?
I don't. DIM. Because you don't know what the acid is in that stomach. Okay. The others, of course, you still need 16-hydroxy, and you also need the 4-hydroxy for bone turnover and everything. When, as a practitioner, when you become a little aggressive with your aromatase pathway blockade, be careful. You do not take that estrogen down too low. In a man, you don't want it more than 35 for estradiol, but you don't want it less than 12 or 15 or 12 either, because then you're not getting the bone turnover and things that you need. So again, monitor by doing another serum, serial finding in about a month after you start your things. And of course, these are some of the things that happen in menopause. Estradiol, these are the 3 estrogens and the normals. You have it in the notes. I'm short on time, so I'll just tell you they're all there for you. Progesterone also can be done by serum, and I told you a little bit of the areas of progesterone, the precursor of progesterone other than cholesterol. What is the very next hormone after cholesterol? Come on. Pregnenolone. So pregnenolone, after pregnenolone, it goes to either cortisol, DHEA. You have the capability by taking one blood draw, getting pretty much the entire schematic of things. I do. That's how you know where to help the patient the best. So it's important. Of course, this is the fluctuation in the menstrual cycle. I also do FSH and LH. It does give you a lot of information. Is that person menopausal? Does that male have a testicular arrest? It gives you a feel of where they are. Remember, premenopause is an 8-year period. You want to get a feel if they're in the middle of that, where they're going. Same with andropause for the male. You want to be able to make sure that they're going in the right direction. And getting LH2 also helps regulate testosterone production. So you'll notice if that LH is changing and the person doesn't have testosterone. Is this because the testicles are now arresting? Probably. Usually it's in the 50s. You start to see that change in men. Growth hormone, not much to be said because I told you it's not good to measure. You're not going to catch it. If you really want to measure growth hormone, you're going to have to do an L-arginine stimulation test with 50 grams of L-arginine. It's dangerous, has to be done in the ER. Since you're not going to do that, you can get IGF-1, readily available, insulin growth factor 1, access. We do it all day. I get it on every single one of my patients. Now, if you're giving growth hormone therapy or replacement or secretagogues, you would expect that to go up to some degree from baseline up. What do you do if you see an IGF-1 that's elevated on someone that's not taking any growth hormone, no stimulants, no hormones? What is in your head as a practitioner? Somebody. What? Where? Maybe not, but it's possible. Just so you're aware, pretty much all prostate and breast cancers, which are very similar, grow with human growth hormone. So by you pushing it, if you push human growth hormone too hard, you'll see the IGF level up. If I see IGF level up, what do? I wait a month, make sure everything's okay, and I repeat it without saying a word to the patient. If it comes back high the second time, I'm looking at the prostate in the men, I'm looking at the breast in the female. That something's growing. Remember, it is growth hormone, typically elevated in the 18, 19 area, maybe a little earlier. So you want to beware. Oxytocin, not assayed by us, but you do need to learn about oxytocin because it does designate and run the microcirculation. Pretty much most heart attacks occur because of microcirculation embarrassment. You should be aware. Yes, Doc? What's what? Yeah, they're all pulsatile. That's why you have to repeat it. All hormones are pulsing. And depending upon what you took, if you took like someone took 3-4 grams or 6 grams of L-arginine, for whatever reason they did that, they'll get slight rise in that too. So you need to look at it. All right, so oxytocin also involved intimately with nitric oxide and the microcirculation, certainly a lecture for another time. Cortisol, of course, and we do laboratory salivary, which we talked about how to do it. It is higher in the morning, as this doctor told us. It's true. Yes? Oh, 5 minutes. Okay. I'm sorry I'm rushing because I have a flight. My flight boards at 11, so it's one of these. I got to go. But just to tell you, cortisol, cortisone, you do convert it. It's also converted by 5-alpha reductase 2 to tetrahydrocortisone, which is inert. If you see that and wonder why it's too high, you may be pressing too hard on the 5-alpha reductase inhibitors. If it's too low, you may not be having enough. But you can also measure this. I do typically measure it in serum as my opening. If I see a serum level, depending on the time of day, being inappropriately high or low, I will order the 4 saliva samples. I will do that as well. We won't talk about ACTH. I don't think I have to tell you how important vitamin D is. If you don't know that by now in this day and age that you should keep it between 60 and 100, then you really don't understand the viruses that are happening around us. Worldwide literature says keep this elevated 60 to 100. Your chances of ever ending in a hospital due to COVID-19 or anything else are very poor. So keep it up. The catecholamines are another day, I think, and we can test for them. This is my contact information. So a husband and 2 elderly folks, a male and a female, decide they're going to get married. She's 88 and he's 94. And they go down, they take a walk, a stroll in Florida where I live, and they go to the corner drugstore, and they go into the corner drugstore, and they say, are you the chief pharmacist? Yes, I'm the pharmacist, I'm the owner, it's a family place. And they said, first the female goes, do you have insulin? Yes, of course we have. Do you have Depends? Yes, we have Depends. The other ones, do you have walkers? Yes, you have walkers. Do you have metformin? Yes, we have metformin. The list goes on and on. Finally, the pharmacist says, well, you're a lovely couple. May I ask why you're asking? He says, yes, we're thinking about using you as our registry. Everybody, hope you got something. Thank you. God bless. Go see the two fellows in the back, Rob and Brandon, for Access Labs. If you don't do Serum, it is so easy for me. It's convenient. It's inexpensive. It's 1, 2, 3. You want a lab that does work and gets it done on time and gets you the information. You're not going to get better. I've tried them all. I've been around longer than probably most of you have shirts. God bless everyone. See you later.